Well, hello everybody. My name is Peter Werwine and I am Senior Editor of Managed Healthcare Executive. And today I'm speaking again to Craig Samitt. He is President and CEO of Blue Cross Blue Shield of Minnesota, as well as its parent company, Stella. We've visited a couple times over the years, but most recently, early on in the COVID-19 pandemic, when we were all getting used to working at home, now rather routine, and when the shape of the pandemic was still uncertain, with various forces were coming into play, the decline in utilization and what that meant in healthcare utilization and what that meant for insurers. Now we are here at the end of 2020, and it seems a little bit like Groundhog Day. We are almost back where we started. So I thought it would be a good time to check in with Dr. Samitt and talk about health insurance, COVID-19, and a lot of other good stuff. So thanks for making the time.
Good to be with you, Peter. Hope you're doing well.
I am. So what has happened in terms of healthcare utilization this year in Minnesota among your members? And where do things sit as far as your medical loss ratio? In August, you announced a plan where there was some fairly generous premium relief, and I think you sent out rebate checks early in July rather than September. I think the total amount of money was somewhere around $48 million or something like that. So
in that ballpark, yeah.
So where do things stand now? Did utilization come back? Are you and how's this shaken out in terms of your rates?
Well, it's a totally different phase, obviously, of the pandemic, Peter. I think the last time we spoke, we neither had a significant volume of cases that were being hospitalized, because it was probably early in the phase of the pandemic, and we also had seen some significant deferral of elective procedures at that time. So as you know, at the very beginning of the pandemic, the systems were decimated in terms of volumes and in terms of revenues because of significant underutilization without a surge of the virus. And I think we may have even talked when I spoke last about sort of the notion that, we thought utilization would come in peaks and valleys. I would say the phase that we're at right now is a double peak. And what I mean by that is, the case frequency and sadly the hospitalization rate in Minnesota is the highest it's been since the pandemic began. And there is limited to no ICU capacity or frankly bed capacity at all within the hospitals. And the reason I call it a double peak is simultaneously, we've also seen the general return of elective procedure work. Not completely, certainly things that are truly elective that can wait will continue to wait. And then there are some things that people just are not going to have done because the issue has resolved. But I think the other thing we're now seeing is something that we were worried about, that I certainly was worried about, that patients that didn't have COVID, but that had other chronic diseases, but were afraid to come into the doctor or the hospital early in the pandemic, are also now sicker and really need the care. So it's a double peak right now because we're both seeing high COVID cases and we're seeing high non-COVID cases, which put us in a very tenuous spot in terms of hospital capacity. And we're at a very challenging time, especially heading into the holidays, where utilization could go up further in the absence of sufficient capacity to care for patients. And so it's incredibly scary at this time. And we very much worry about how we're going to successfully care for everyone who needs care in Minnesota over the course of the coming months.
And are there any, in terms of I'm sorry, in terms of the peak that is concerning people that deferred care. Have you seen any patterns about what sort of diseases are, because care was deferred, are resulting in more serious illness and therefore, a greater number of hospitalizations or expensive interventions? I mean, is this happening with respect to cancer patients, to heart failure patients, to kidney patients? Is it breaking out that way at all?
It's not really so much cancer patients, thankfully. I think with several of our partners, we've seen that care for cancer patients, and frankly, the volume in oncology clinics and infusion clinics have really stayed relatively stable through the course of the pandemic, because if you're on a chemotherapy cycle, it's not like you're going to stop that. You're going to want to continue it. So I think the underutilization has mostly been seen in chronic diseases that require regular follow-up. So cardiac disease, congestive heart failure, diabetes, pulmonary disease, things that do require more regular touch base and regular maintenance. Those are the sorts of things that I think we're concerned about, the implications of insufficient care and service on a regular basis. I think what we've also seen more of are diseases that arise because maintenance is deferred. So while we're not so much seeing concerns about utilization related to people who have already been diagnosed with cancer, if folks were not coming in for mammograms or other types of screening tests, then the identification of a diagnosis can be late, and we want to catch disease early. So I think the other thing that we're concerned about that we're seeing in higher volumes are the output of a deferred screening and prevention and wellness strategies.
Now, as you know, there's a body of evidence that a fairly large portion of medical care is unnecessary or inefficient. And I've read in some things and have a writer working on a story about whether COVID-19 might mean that some of this low value care would get sort of squeezed out of the system. Do you see that as a possibility, that some of this care that wasn't delivered was low value care, and we might see a benefit to that?
I think there is ample, there has been ample research, literature, and materials written about the frequency of low value care that we see in our industry. And frankly, that's what we get when we live within a volume-based fee-for-service system. We have really not been a health care system. We've been a sickness system, and much of that is motivated by reimbursement for doing more tests, more procedures, and in a volume-based system, the more we make, the more we generate. And so there's certainly a component of the care that we've received, which is unnecessary, and not just unnecessary, but unsafe. If we do unnecessary testing or identification of diagnoses that then lead to procedures that have a bad outcome, if a patient would have been completely unaffected by that diagnosis, then they now leave worse than they started because of significant overuse. And so I do think that is one of the silver linings of this for two reasons. One is, when we receive care in a more traditional setting, historically, when we would go to the doctor's office, we would come to the doctor's office, and yes, we would have a face-to-face encounter with a physician, but more often than not, we would also get an X-ray, blood work, and maybe a prescription that we may or may not need. In a world that is more virtual or cloud-based or telehealth-based, I would still have an encounter with a physician virtually, but I probably wouldn't get those unnecessary additional services, unless they were truly warranted and truly needed and the medical evidence would support it. So I think that one of the potential benefits here is that a redefinition of the care model is going to lead to a focus more on high value and less on low value. I think the other reason why we're likely to see a change, one of my predictions that I think we've talked about before, is the likelihood that this pandemic will lead to an evolution of the payment model. I've long been a critic of the fee-for-service model for the reasons we just discussed. But in a world that pays for outcomes or quality or longevity or population health, then I don't want to, or I don't need to do more things. I, as a physician in a value-based model, am rewarded to keep you well, to make sure that you're receiving all your preventative services and you're getting all your screening, and that you avoid needing to come into the hospital where people don't want to go right now. So I think either because the incentive model will change or the care delivery model will change, I would predict we will see a decrease in low value services.